I have, but I carry feedback sometimes.
Oh, right, okay, that's right. Yeah, I've done half term.
I know you're doing quite a lot of it.
But I haven't really got more dates for March, but Jane is now sick with her mum. Luke was off all last week.
So I think it was quite strong.
It's a tax year, really. But then since April.
She's off this week and she's back.
Very hot topic.
Very dangerous, very hard. Myself and Ruth, we're commissioning the local butler right at the beginning, so we've seen it sort of expand and develop. It's not like I'm any expert whatsoever, it's like that you've just been involved in the pathway and sessions, but it is very helpful.
Also raising the issue, but at the same time giving a clear message.
Yeah, I hope it's okay. Half an hour is not necessarily long enough, but part of the role of the GP champion is especially I think it's this role, rather naive to assumption that they give you the job on day one, you do your training. By the following week, you're going once a week to a surgery to spread the message, but that's not how real life is, because the surgeries don't have time to have you. If you're doing bigger sessions like this, you get a greater hit rate of different practices, because the target after the first spotlight group was that you've done some level of education to, I think, 50% of the practices in your area over that 6-month period. But I mean, this is probably a few different practices here once I look at the feedback. I've got a nice long session with GP registrars, which are education specialists, which we've come to do with this, and do quizzes and things.
You go there and GP surgery.
Yeah. If they invite me, but 2 newsletters, this is just a regular newsletter. I've advertised twice if anyone wants to get in touch. I can come in, I'm flexible, so more or less semi retired anyway. The only two people I've got in contact with are GPs that work in private practice, or go to sneaky look at the newsletter all the time. But it's really only GPs are so fussy and such a rush at the moment. I used to be the name GP for safeguarding as well. It's really hard to get into surgery. It's busy, and you almost have to build this little protective wall around yourself to survive, it seems. And education, I think, is by the by, unless unfortunately some very scary stories of very, very distant stories. There's some very wonderful stories of when it goes right there. It's up to today, especially when you even if I just go to registrar groups and things. I've got something organised for BTS.
Sorry, we need to start again. Sorry, I'm terribly sorry. Yeah. Sorry, we need to start again. Okay, I'll while you are going back to your tables and seats, I'd like to spend the next 20 minutes to present a study we published recently in the Lancet about antidepressants and depression. The reason why I'm very happy to talk to GPs is because these kind of patients are seen in primary care. Before moving to the UK, I'm Italian. 5 years ago I moved to Oxford. I used to be a psychiatry in a community mental health team, so we saw a lot of patients with depression because the Italian system is slightly different from the UK. Now my focus, I'm a clinical academic and I see people with bipolar disorder and treatment-resistant depression. So I'd like to have your feedback about what is the clinical implication of these findings. Of course, because we're talking about antidepressants, I've never received money from any pharmaceutical company. You can ask my wife. Never, and never will. My field of interest is evidence-based mental health, evidence synthesis. And this is what I don't think you can see at the back. Basically, this is the hierarchy of evidence, what we teach to medical students. So when we have to, depending on the question, so we have to assess the efficacy of an intervention, pharmacological or no, the hierarchy of evidence says that randomized controlled trials are the top, level 1, level 2 is observational studies, because with randomized trial you rule out the risk of the so-called selection bias. And the reason why we have 1A, 1B is 1A is a systematic review of randomized controlled trials. Systematic review means you collect systematically, so in a transparent and replicable way, all the information about a specific question. Are you happy? Yes. Why? Why? No. Are you happy? Sorry. No. Sorry, that's my bad English. Are you happy with the hierarchy? Not in life. Are you happy with the hierarchy? Yeah? Everybody's happy?
Yeah.
I'm not. I'm not, because I don't think this really helps the clinical decision making. And I try to prove it with a clear example outside psychiatry to make you a general argument. And this is a very good review in terms of quality of the review, published in a very good journal by very good authors. So here the problem is not the quality of the content, it's more about the methodology itself. So safety and effectiveness of methods of earwax removal. So if we look at the abstract, which is something we should not do because it's very advertising material. But in the end, in the results section of the abstract, I can read for the people at the back. They say, on measures of wax clearance, ceramol, sodium bicarbonate, olive oil and water are all more effective than no treatment. This is the first finding. Second, TP is better than olive oil. Third, wet irrigation is better than dry irrigation. Fourth, sodium bicarbonate drop followed by irrigation by nurse is more effective than sodium bicarbonate drop followed by self-irrigation. So, where's the problem?
You haven't reviewed the self.
Sorry?
You haven't reviewed the self.
Yeah, but as clinicians, what is missing here? I mean, you have 10 minutes for each consultation in your GP surgery. So what is the problem here?
Too many options.
Exactly. So how can I choose among these options? Is it possible to use evidence-based medicine to rank the treatment options and be able to understand which is, if any, the difference between the treatments? Because in a systematic review and meta-analysis, we don't answer what ideally clinicians would like to know, which is how will the different options rank against each other and how big are the differences, I think. This is what at least I want to do. And this is a nice paper to show that it's a general problem. So why olanzapine beats risperidone, risperidone beats quetiapine, quetiapine beats olanzapine. So it doesn't make any sense as a circle. Okay, so we have developed this methodology called network meta-analysis or multiple treatments meta-analysis. And the key assumption is that if we have a set of trials comparing treatment A with placebo, and a different set of trials comparing treatment A versus treatment B, okay, so two different systematic review and meta-analysis, what we can do is to use the treatment in common, A, to compare indirectly B versus placebo, which is not compared in a direct trial. Okay? So network meta-analysis means using indirect evidence. How does it work? So this is a real example of a network of treatments. These are all antidepressants. The size of each node is proportional to the number of patients randomized to each antidepressant, and the lines represent the direct comparisons, the trials. The width of the line is proportional to the number of trials comparing to drugs. So a lot of patients randomized to fluoxetine, not so many to duloxetine. Many trials comparing sertraline with fluoxetine, only a few trials comparing paroxetine and duloxetine, no studies reboxetine mirtazapine. So, milnacipran, it is a drug not that similar to venlafaxine. So it's serotonin and noradrenergic reuptake inhibitor. The reason why milnacipran is in this network is not licensed in this country, but it was a project with also researchers from Japan, and it's the only SNRI in Japan. Forget about milnacipran. Reboxetine mirtazapine, we don't have any trial. So if the question in my surgery is, should I prescribe reboxetine or mirtazapine, I do a systematic review, no studies. So what we can do is to use a common comparator to calculate the indirect evidence mirtazapine, reboxetine. I can use, for instance, fluoxetine. I have trials reboxetine, fluoxetine. I have trials fluoxetine, mirtazapine. I can calculate the indirect evidence. So I fill the gaps in the network. But the other great advantage of network meta-analysis is, let's say, we have a lot of studies comparing sertraline versus fluoxetine. So I have the direct evidence, solid red line, but I can use the network to calculate also the indirect evidence, sertraline, fluoxetine, via a common comparator like venlafaxine. So the dotted green line is the indirect evidence calculated sertraline, venlafaxine minus venlafaxine, fluoxetine. And this is great because I can then compare the consistency between direct evidence and indirect evidence. Because in the ideal world, the difference between the two should be the same if I compare them directly or indirectly. This is called inconsistency. And the other assumption of network meta-analysis is called transitivity. So each patient in the network, ideally, should be randomized to any of the interventions within the network. So the information flows across the network and across different comparisons. Okay? And the other thing is the indirect evidence searching fluoxetine can be calculated via any of the closed loops, so any other comparison which is in common. Okay, so I use the whole evidence. So these are the advantages of network meta-analysis. As we said, we can compare interventions which haven't been compared directly, fill the gaps, comprehensive use of all available data, we can improve precision, and we can also rank the treatments. Okay, so this is the paper published last year in The Lancet. What we did was to look at 21 antidepressants and placebo for the treatment of acute major depression. We had two questions. One was basically, there's a long-lasting debate about whether antidepressants work, and second, if antidepressants work, are there differences between antidepressants? As I said, the focus was acute treatment of adults with major depressive disorder, because when you do a systematic review, you have to specify a specific question. It cannot be acute and long-term in the same review. We are running parallel projects to tackle the issue about long-term treatment, but this evidence is about acute. And we compared all licensed second generations. We also use 4 old antidepressants, which are included in the WHO list of essential medicine because we wanted to inform clinical practice globally. And of course, we included placebo. Quickly about the methods. Because we have placebo, we wanted to include only double-blind randomized controlled trials, published and unpublished, because we know that the unpublished literature is more objective, or the other way around. Published trials tend to favor the drug over placebo, so it's important to include unpublished data. Oral monotherapy, the kind of patients you see in your practice, adults, standardized diagnosis of major depressive disorder. We searched all the trial registries as well to find the unpublished data, and we contacted the authors to have supplemental information. This is the list of 21 drugs in alphabetical order, the second generation until vortioxetine, and then the 4 standard or old drugs, amitriptyline, clomipramine, trazodone, and mefazolam. Okay? Imipramine is not here. Why? It's not one of the WHO list essential medicine. For the transitivity, we had to exclude bipolar disorder, psychotic disorder, postpartum depression because it's a different population, serious concomitant illness, and we look at outcomes at 8 weeks, so very acute term data. The outcomes are response, number of patients who responded, 50% reduction on a rating scale, and all-cause dropouts. Assuming that if after 8 weeks you're still taking the treatment, somehow you respond to treatment and you can tolerate. But we also look at specific outcomes like how the symptoms change, how many people remitted, and also how many dropped out because of adverse events. We are working now on the analysis of the specific adverse events, but here is just dropouts due to adverse events. Of course, the data, the studies, where we included data only within the therapeutic range. I can skip the statistic analysis, but I want to tell you that, well, 2 things. One is, network meta-analysis are very complicated research projects and very multidisciplinary. So we have clinicians, methodologists, statisticians. I asked 3 different statisticians to ask the same data set with 3 different softwares, just to be sure that data and results were consistent. And when you do a systematic review, you also need to appraise the quality of the evidence, which is now called certainty of evidence. Okay, this is the flow chart to show how we selected the references. We started screening about 30,000 hits from the searches, and here you can see that The electronic databases identified 421 studies, but additional 86 came from the unpublished data. So a relevant amount of information is unpublished, and this is the detail about individual drugs versus placebo or another active comparator. Of course, fluoxetine, 117 randomized controlled trials. Desvenlafaxine, very recently marketed, only 9. That's expected. So the body of evidence is slightly different. So this is the network for response, efficacy. This is the network for acceptability, dropout rates. 2 things. One is the network is very well connected, so I can calculate the consistency direct, indirect. And the second is that efficacy and acceptability, the network is basically identical. So the same patients who contributed to the analysis of efficacy are also contributing to the analysis of acceptability, which makes sense because we planned to have these 2 as the primary outcomes. Efficacy. First questions, are antidepressants better than placebo? In terms of efficacy, this is a forest plot, so the standard way to represent meta-analysis, but these are network meta-analysis data. So it's combination of randomized, direct and indirect. And you can see that all antidepressants are better than placebo. But some antidepressants are clearly better than others. If you look at the acceptability, this is the line of difference. Basically, all antidepressants are no different than placebo. The 2 that are slightly more acceptable, the confidence interval is so close to the line of no difference that in the end, clinically speaking, it's difficult to say that they are more acceptable. And the same for clomipramine. It almost touches the line of no difference. So the take-home message is that there are differences in terms of efficacy, not really in terms of acceptability, antidepressants versus placebo. What happens head-to-head? So this is a graphical representation of acceptability versus efficacy of all these drugs. 22 is placebo, and you can clearly see that all the drugs are better than placebo, and in terms of acceptability they are pretty the same. But if you look at 16, which is reboxetine, the least effective drug, look at what happens if, rather than analyzing all the studies, including the placebo-controlled studies, look at what happens if we analyze only the head-to-head. If we analyze reboxetine is the same position, so we excluded placebo, this is the ranking. This is the differences. Why is this happening? Because in the end, if you include placebo, differences shrink. You see the difference. So we try to understand why, and this is another paper we published a few months after. And we found this, which is amazing. So if you look at response versus dropouts, so efficacy, acceptability, for the same drug, in a placebo-controlled trial versus in a head-to-head trial, in a head-to-head trial, the same drug is more effective and better tolerated than the same drug in a placebo-controlled trial. Why? There may be 2 reasons. One is methodological. Of course, if you are randomized to a placebo-controlled trial, you don't know whether it's the drug or placebo, so you may drop out early because you don't know whether you are randomized to an active drug or not. So we cannot measure the contextual response in a placebo-controlled trial. There's only one way to do it, to cheat to patients. You tell the patient this is a placebo-controlled trial, this is actually in head-to-head. This is not ethical. We have examples in pain where they do this kind of studies, so we are working on this, but it's very difficult from a methodological point of view. But this is the other explanation why the results are skewed basically in the placebo-controlled trials. Look at this. This is the standard outcome in a head-to-head and placebo-controlled trial. So these are the wicks, and this is the change on the rating scale. So this is the improvement. This is placebo. This is the drug high dose, drug low dose, and comparator. After 8 weeks, the difference between placebo and drug is, let's say, 5 points on the MADRS, which is significant. But I just showed you that if I am in a placebo-controlled trial, people drop out after 1 week. So what the trialists do, in order not to miss this data, is to take the last observation and they carry it forward. So they do this. Last observation carried forward. So the study stops here. Rather than throwing everything in the dustbin, we carry forward this information and we say that the difference is actually what we found after 1 week. So in the end, the difference is 1 on the MADRS rather than 5. 95% of the studies in our analysis use this design. So this is why when we reported all the data in one table, efficacy versus acceptability, we use the head-to-head trials, and you can see that the column defining versus the row defining, you can see the individual head-to-head comparison. Highlighted and bold are statistically significant results. You can't see the figures, but you can see, hopefully, that there are many bold and highlighted cells, which means there are differences between antidepressants in terms of efficacy and acceptability. Okay, there are many limitations. Missing studies, quality of evidence, which is quite average to poor. We didn't do any cost-effectiveness analysis. Of course, the outcomes are more not just response or remission, but this is the key point. So we are talking about averages. And this is what I'm working now with this NIHR grant here in Oxford, and I hope to recruit you for my study, because the challenge is to personalize treatment. So what we do is basically to use individual patient data to develop a treatment algorithm, which is not just about the evidence, it is also about patient preferences. So in this algorithm, we will have the ranking of treatment, but the ranking of treatment is based on patient preferences and doctor's preferences. Or, for instance, we can ask Nick his preference about the adverse events. Of course, this is just an example. We are working on this, but the idea is that, for instance, Nick doesn't want sedation, doesn't want weight gain, but doesn't really care about nausea. But as medics, with a QTC prolongation, we say, well, the cardiac risk is almost null because there's no QTC prolongation. And this is the ranking of the antidepressants. We say escitalopram, fluoxetine, blah, blah, blah. But for Steve, the same kind of patient, but he doesn't want nausea, he doesn't want tremor, and he has a QTC prolongation, the ranking is completely different. So we are developing this algorithm to be tested in clinical practice. So just to wrap up, if you want to know a bit more about network meta-analysis, we published this paper. I'm the editor of this journal, Evidence-Based Mental Health. The paper is absolutely free, so open access. You can download, and it's a stepwise approach to explain how network meta-analysis work. Of course, we also ran this course in Oxford. It's the only one in the world for clinical researchers and clinicians to understand, clinically appraise, and also publish network meta-analysis. If you think this is too advanced, from this year we started organizing a course about systematic review, which is the standard systematic review and meta-analysis. So if you have any question about these courses or everything, I can send you also all the full text. The last 2 words are about the framework to do this, which is called the BRC, the Biomedical Research Center. Now in Oxford we have this opportunity, which is a way to promote clinical research and translational research into practice. And because we fund studies, we also have dedicated clinics for people with bipolar disorder and treatment-resistant depression. We know that many people who are with treatment-resistant depression are in primary care, and if you refer these patients to the secondary care services, they are often bounced back to the primary care. So thanks to the BRC, we now have dedicated clinics, so you can refer directly to us, these patients, and we can take care of these patients under one condition. that they are happy to be involved in research. Okay, thank you. Yeah. I'll be around, so if you have any questions, we can discuss this later. Sian? Chan? Sorry. Well, almost at time. Sorry. Yes.